All right, good morning. This is the Senate Health and Welfare Committee meeting of January 12th, 2022. Thank you all for being here. This morning, we're going to be taking up S74, an act relating to modifying the Vermont's patient choice at end of life law. Then we'll be looking at S91 related to parent-child centers. And finally, we're going to pick up on COVID issues at 11 o'clock. And we have some hard stops that we're going to have to make to ensure that folks who are available for testimony can get their testimony in. One correction that was made to the agenda, I see it's already been made. Thank you, Aaron. Mary Han Beerworth is unable to testify this morning. We'll try to get her in as early as Friday so we can finish the work that we need to do on S74. So good morning. We have with us Diana Barnard, and why don't you go ahead with your testimony? We have some things, and we've seen you in this committee before, and it's a pleasure to see everyone back. It's great to see familiar faces, I have to say. So I'm just sorry we're not in the State House, all cramped together in that little tiny room of ours under better conditions. Diana, welcome.
Thank you. It's great to see some familiar faces and also some new ones. I want to just briefly remind you of the qualifications that bring me here today. I am a lifelong Vermonter, and I've spent my entire clinical career taking care of Vermonters. I'm board certified in family medicine and also in hospice and palliative care. My current clinical work is as the lead physician at the University of Vermont Health Network Porter Medical Center Palliative Care Service, and I also work as a hospice physician. I was, as Jenny was indicating, actively involved in the efforts to pass our initial medical aid in dying law. I continue to be on the Patient Choices Vermont board, and I am also on the clinical advisory board of the Academy of Medical Aid in Dying, which is based out of California. I've been working in medicine for 28 years, and the last 12 years of my practice has been focused exclusively on taking care of people living with serious illness. I just feel the need to start by reminding you that how we die matters, and that we only get to do it once, and that you enter it with no previous experience. And this is true for the person who dies, and it's also true for the bereaved and the loved ones that are left behind, because the experience of witnessing somebody dying has an effect on how you approach your own death, and that ripple effect can go through generations. So it is imperative that we continue to refine and explore ways to meet the needs of people who are dying. As many of you know, we've just had a recent report from the Vermont Department of Health that has clarified our experience in Vermont over the past 6 years has been as expected. The numbers show that the vast majority of patients who access our law are living with cancer, more than 75% of them. The next most common diagnosis is ALS, followed by other neurodegenerative diseases. We have an average of 14 to 15 people a year who are completing the process for medical aid in dying. And those numbers from the Vermont Department of Health do not show any instances of abuse, which is very important to keep in mind. So our law is working very well. However, at the same time, the past 6 years of experience has shown us that, like with many laws, it's an opportunity to tidy it up and to fix some unintentional issues with the law, which I would like to briefly review with you today. The first issue is one of immunity. Other people will speak more to this, but I will simply say that our law somewhat unintentionally only focused on immunity for the physician participating in the process. And explicitly, they are the only ones who are protected. And even though there is implicit understanding that others would be protected, this has proven to be an issue, particularly with pharmacists who would want to participate but worried about protecting, understandably, their license. And so we are asking you to make that protection for pharmacists and other members of the healthcare team explicit. The second issue, which we are asking you to address, is the final 48-hour waiting period. We have waiting periods built into our law to assure that patients have adequate time to consider their treatment options and are not rushing to a decision. It's really important to have safeguards. And it's also important to recognize that sometimes safeguards can actually become barriers. And I believe we have a mismatch in that balance in our law, which we are asking you to address today. Almost every patient I meet wants to live as well as possible and as long as possible. And particularly in the setting of a serious illness, most patients are focused like a laser beam on their illness and the treatments that are available to them to help them live well and live longer. And at the same time, as your illness becomes more advanced, your physical and emotional energy can rapidly decline. And so by the time patients are realizing that their treatments are no longer working as well as they had thought, time is short and physical and emotional energy is short at a time when people have very important issues that they want to be focused on in bringing their life to a close. I can tell you that virtually everybody that's been diagnosed with a terminal illness has thought about dying and has wishes for how they want to die, even as they're focused on living. Oftentimes, those wishes have not been explicitly talked about unless the patient has had the services of an expert person to bring out those worries. And so those worries about how we die often come to the table very late in an illness. Most people who have interest in medical aid in dying have talked about it and thought about it for a long time, and many times family is aware, but they haven't started the formal official process because they are focused on living and getting treatment. So what happens is by the time people realize that treatment is not working and their time is short, energy is also short. So just to briefly review the process that patients go through for medical aid in dying, they have to make a formal request to the prescribing physician. More than 2 weeks later, they have to make a second request. There has to be a consulting physician to confirm the patient's eligibility. And that patient also has to take the time to put their wishes in writing and have that wish witnessed. Our law requires at this time, after all of those steps have been completed, an additional 48-hour waiting period before the prescription can actually be written. No other of the 11 states, 10 other 11 states in jurisdiction that allow medical aid in dying have such a requirement. And in my experience and the experience of other clinicians that I talk to, this 48-hour period offers no meaningful benefit and has created a burden. Patients have thought about the process, they've made their requests, and they are, by and large, by that point, ready to move forward with having that medication access in their back pocket. So we are asking you to eliminate this final 48-hour waiting period, knowing that the other safeguards will remain in place. And the other issue, of course, that we're addressing today is the issue of telemedicine. As we know, medicine's a constantly changing science. We're always learning new things. And when our law went into place, frankly, telemedicine was just not at the forefront. We know that telemedicine has been used in other areas for a number of years, quite successfully. Now, the best example of that is really within the VA system. I suppose thanks to the pandemic, over the past 2 years, we've really seen in Vermont how telemedicine can be effectively used in order to provide timely and high quality medical care to Vermonters. And we believe that telemedicine should be incorporated into medical aid in dying as it is in any other area of medicine. I also want to say, just as an aside, that in my practice as a palliative care physician and a hospice physician, my biggest clinical tool is my presence and my ears and my voice and responding to suffering. I use my eyes to evaluate the patient and my ears to listen to suffering. And actually, in my clinical work, it's very common for me not actually ever to have to lay eyes on the patient. Excuse me, lay my hands on the patient. So my hands are useful in some clinical situations, but largely not in my clinical work. I thought it might be useful just to kind of run through what would a telemedicine visit look like. So if I were going to see a patient to explore suffering and their end of life wishes, I would start by reviewing their medical record. I would look at all of their notes, their lab results, their x-rays. I would look for those specialty notes to tell me how the disease has progressed. And I would look for prognostic data that lets me know that the patient's illness is in its final phase. Then when I'm on the telemedicine visit, I would start with introductions. I would begin by getting to know my patient, by exploring their values, by learning who they are, how have they lived their life, what has been their experience with illness, what are they worried about, what are their biggest fears. I would always be listening for sources of suffering. What is bothering the patient most, and what could possibly I do to address that suffering? So always looking for therapeutic interventions. I would be listening to their request for medical aid in dying. I would be reviewing all of the requirements of the law, in particular focusing on their understanding of the illness and their capacity to move forward with the law. During that visit, I am continually looking for anything that tells me that this telemedicine visit is not accurate and I need an in-person visit. And that could happen at any time. Maybe there are technical issues. Maybe there are communication challenges over the technology. All of those things would encourage me to pivot to an in-person visit. If I was continuing with the telemedicine visit, I would use what I do in an in-person visit, which is my ears and eyes to assess the patient. I can hear if somebody's short of breath. I can hear if their voice is very weak because they're living with serious illness. I can hear them cough. With my eyes, I can see if they have signs of advanced illness. Are they thin? Are their clothes loose fitting? If needed, I could even have them use the camera to show me any tubes or accoutrements that are part of their body, to look at their tummy, to look at their edema. It's very effective as a way to assess what's going on with the patient. And continually, my biggest clinical skill are my ears in listening to the patient's worries and their understanding, and my words to assure them that we're going to do anything possible. At the end of that visit, if all went well, I would close and schedule a follow-up. So I believe that telemedicine could absolutely be effectively used to help assess the patient's eligibility to move forward with law. I think I want to close by just telling a story. And this is the story of Lynn Ashay, who was a woman in her 60s from Arlington, Vermont. And unfortunately, her case actually articulates all three of the issues that we are talking about with our law. Lynn was a competitive athlete. She actually was the first woman to bicycle to the top of Mount Washington. And she was incredibly healthy and had no risk factors for the disease which she would get. In late winter of 2019, she developed a cough that was eventually diagnosed as pneumonia. And she had treatment, but she had a lingering cough that lasted several weeks, which prompted a more extensive evaluation, which unfortunately revealed evidence of widely metastatic lung disease. As you might imagine, Lynn was in shock, and she and her husband, Tony, immediately began to explore their treatment options and preparing for the end of her life because her disease was at such an advanced stage at the time of diagnosis. Lynn had previous experience with dying. Her father had had a very difficult, painful final phase of life, which had really traumatized her as a daughter. And she was very clear and articulate in her desire to not experience such a terrible situation for herself. Because of the waiver that our willing pharmacist requires physicians to sign, she could not find a willing prescriber in her area. Eventually, she reached out to me in June of 2020, and I agreed to see her. This was in the middle of the pandemic, and I was balancing so many clinical needs that I did not have the time to be able to travel to her. So Lynn and Tony had to drive an hour and 45 minutes each way to come to my office. And they had to do that on 2 occasions. I learned only after the fact that for that second visit, Lynn, who, remember, was a competitive athlete who had a very high bar for how she wanted to live her life, actually begged Tony to call an ambulance because she was so exhausted and uncomfortable. She wanted to lay down on the way to my office. And I will never forget going out to the car on that second visit to help Lynn get out of the car. And Tony had fashioned a camping mattress on top of the reclining front seat in a desperate effort to get Lynn to be as comfortable as possible. During those 2 visits, despite advanced physical illness, Lynn's mind was very sharp, and she was very clear in her wishes and clearly qualified for the law. Our last visit happened to be on a Friday. And while Lynn was still interested in living as long as possible, because remember, she had only been diagnosed in April, and this was June. So she still had things she was trying to do, but also desperately wanting to plan for a death that was not going to be like her father's. So she wanted to have the prescription waiting at the pharmacy and ready. We discussed how I had to wait the 48 hours. It was a Friday. And so I said, very first thing the next week, I'm going to send the prescription off. Unfortunately, over the weekend, Lynn's condition first began to deteriorate, which told her she wanted to move forward as soon as possible with the law. But second, over just those 2 short days, her condition further deteriorated and she lost the capacity to be able to participate. And by early next week, she was left in a condition and lived for 11 additional days, exactly in the kind of situation she did not want, with Tony as her caregiver and witness. Despite his grief, Tony was frustrated and, quite frankly, angry about the ways in which Lynn had faced these barriers to the law. And he wrote many people to talk about his experience. And some of you have actually probably heard this story before. I am haunted by that experience. I think anybody who knows my clinical work knows that my bar is very high, and I have high expectations of my ability to offer people comfort in their dying process. And in this case, I was not adequately able to address Lynn's issues. And from that time, I became determined to move forward with fixing the law so that others would not have to suffer the fate that Lynn did. I actually called Tony this week to check in and see how he was doing. It's been about 18 months since Lynn died, and he was the one who encouraged me to share her story. So I think I will stop there. I really appreciate you listening, and I would be very happy to take any questions now or later.
Thank you very much, Dr. Barnard. And I'm going to ask you if you can send us some written comments if you have a few minutes. I know you're busy, but if you could get that to us, because I don't see it on our webpage.
Yes, there's been a lot going on, but I will get you my written comments by the end of today.
Oh, okay. That would be terrific. Thank you so much. Committee, unless you have a significant question of clarification, I'm going to suggest that we move right along in our testimony. Senator Hooker.
Just a clarification, Dr. Barnard, on you mentioned other members of the health team besides the what do I want to say? Pharmacist, besides the pharmacist. Could you just elaborate on that, please?
Oh, I was referring to other people who may be involved in the care of the patient. I actually need to say that I'm having a little brain cramp and can't remember the specific language of the law, but we know that there are others helping to care for patients living with serious illness. And I would hope that other members of my team could address that issue.
I'm sure we'll hear more about that. I know we're going to hear more about that particular section. So that's a very good question, Senator Hooker. Thank you. All right. Why don't we move ahead and we'll ask Betsy Walkerman. Thank you for being here. And why don't you introduce yourself for the record? And I do know that we have your testimony on our webpage.
Yes, I submitted some backup documents, but if you want the
Betsy, we're having difficulty hearing you. You're going in and out as you speak.
Let's get this closer.
That was better. As soon as you moved a little closer.
Okay, I'm just moving closer to where my actual speaker is. Is that all right?
Yes, it is. That's fine. Thank you.
Okay. So so thank you. Good morning. Thank you for the opportunity to testify on making some improvements to Act 39. I'm president of Patient Choices Vermont, and I'm a lawyer. I've worked on medical aid and dying for the past 20 years since I started work with my parents, who many of you know, Dick Walters and Ginny Walters, to launch Patient Choices Vermont. Can you all hear me all right? Yes? Okay.
Well, when you face directly into your, or whatever the mic, wherever the microphone is, we hear you perfectly.
Okay, great.
Yeah, that's good.
You can move that a little closer. I'm sorry, I thought I had all this set up exactly right.
That's good right there.
Right there, okay. As I mentioned, I head up Patient Choices Vermont. PCV is a nonprofit organization, and we're focused on educating Vermont residents and the medical and caregiving communities about medical aid and dying. And our volunteers answer about 6 to 10 calls per month from patients and doctors. And we connect any doctor who has not participated in Act 39 before with knowledgeable colleagues such as Diana OBrien. And we train hospice and medical personnel. And the PCV website, patientchoices.org, has extensive resources, including videos of Vermonters who have used medical aid in dying. And I would encourage you to listen to the voices of the people who've made this choice. It's made such a huge difference for people working, who are living with terminal illness. You know, there's a real family and a real person behind every one of the 116 people who have filed for medical aid in dying since 2013. We've received a lot of notes of gratitude, which actually really should be forwarded to all of the legislators who made this possible. Vermont now has experienced doctors and hospice nurses and an excellent pharmacy, a compounding pharmacy, which is what's needed to develop the drugs and the medications that are used in medical aid and dying. And that pharmacy delivers the prescriptions where needed all over the state. In parallel, I would say that hospice use in Vermont increased 26% since 2013. I know this was a topic of discussion when the law was being considered. So there's been a very big increase in hospice use. And so that today, almost half of the people dying in Vermont are using hospice services. I'd really like you to hear directly from the patient. So I'm going to play a short clip from a young cancer patient named Karen Olschlager. So let me just hit the go button here.
Everyone was clear to me, you can always go through the process and not use medication. And I knew that. Right now, as I get sicker and sicker, it looks more likely that that will be a tool I'll actually utilize. But I've been grateful to have it there in the toolbox nonetheless. I am so grateful this is something I worked through mentally and emotionally 2 years ago. I think there can be a lot of pressure in our society to keep fighting, especially as a young cancer patient. And I think what folks don't always realize is sometimes that keep fighting is really just a lot of prolonged physical suffering. It gets worse and worse. I am grateful for all the providers who have agreed with me that this is a valid option, to take some control during this process, which is such a profound loss
I hope you could hear that all right.
of control. And
Yeah, so Karen's whole video is on our website under the video section. And it's really enlightening about what actually goes on for a patient who's considering Act 39. So when Act 39 was drafted, legislators gave a lot of attention to preventing improper use of the law. And as a result, there's quite a list of requirements. There are 5 qualification requirements. There's an 8-step procedure that the patient and the doctor have to go through, and there's full documentation that is filed with the Vermont Department of Health. Every person qualifying for aid in dying has to go through, must be diagnosed by 2 doctors as having a terminal illness with 6 months or less to live, and they must be capable of making their own medical decisions. And participation in the law is completely voluntary. So just by way of background, I filed in the written testimony a graphic flow chart which shows the procedure for your reference. Medical aid in dying is much more established across the country than it was in 2013, and Kim Callanan from Compassionate Choices is going to speak to that. In our 8 years of experience, PCV has not received a single report of suspected abuse. Yet we do know how onerous the process is for dying people. So we really think it's time to make improvements and appreciate your consideration. So I'm going to just run through the 3 aspects of the law and perhaps fill in any gaps that there might be in understanding. So the first change is that it would remove the requirement that requests for aid in dying be in the physical presence of the doctor. And we have included in our testimony and a table comparing the laws in the 11 states across the country and looking at the specific provisions that are in Senate Bill 74. And you can see that Vermont is the only state among the 11 where requests for aid in dying have to be made in the physical presence of the doctor. And can you just give me a thumbs up or a thumbs down? I would play a quick clip from Karen Olschlager again about her experience trying to get to the doctor when she was so debilitated. Thumbs up? Okay.
I had to physically go get myself in front of this doctor, which is hard when you're dying. So I was profoundly malnourished and dehydrated and vomiting pretty much constantly. So it's rough to drive 45 minutes and sit in a waiting room and, you know, have to get dressed and engage with someone who you know you might puke in front of. I mean, by the time I was talking to the actual physician, I thought about it for literally years. So yeah, I think removal of that requirement would be just a huge relief.
Yeah, having had conversations with Karen through this whole process, it hits me pretty hard, and I think you'll find the same if you listen to Karen's video on our website on the video page, as well as a recording from Dee Allen, who you may know. She was the resolutions clerk at the State House for many years, and she used Act 39 last year. So then the second part of Senate Bill 74 would fix the technical error that Diana Barnard mentioned, which provides explicit legal immunity only for the doctors in the process. And it would clarify that all the parties who act in accordance with the law, which could be family members, it could be hospice workers, and of course the pharmacist, would be free from claims of immunity. So I'm going to take just a minute more on the pharmacist, because that's where the real issue has come up. Because the law is just implicit, not explicit about their immunity, the principal pharmacist who fills prescriptions in Vermont requires doctors to sign an indemnification agreement. And many doctors are not willing to sign it. It's a very unusual requirement for a doctor. So this has reduced the number of physicians who are willing to prescribe, and it's created pockets in the state, especially in southern Vermont and up in the Northeast Kingdom, where patients have trouble finding a doctor who will prescribe and who will work with them through Act 39. With the Senate Bill 74 amendment, the indemnification agreement would no longer be required. And the pharmacist has confirmed to us that that is the case. And so we would expect the number of participating doctors to increase, and especially local doctors and doctors who might have longer relationships with the patients. So as you'll see in the table that compares the state laws, all of the other state laws provide immunity for all the people who were involved in the process in compliance with the law. The third part of Senate 74 would adjust the steps required to get a prescription. The proposed amendment keeps the 15-day period between the two oral requests. It keeps the requirement for 2 doctors in a written request, but it removes this unnecessary and burdensome last 48-hour delay. 48 hours may not seem like much, but to a severely ill patient, it can make the difference between being able to qualify or not. And Vermont's timeline, again, looking at the comparison of the states, we were early in the process. You know, Vermont was the first state that that passed an aid in dying law through legislative action. So now that there are 11, there's really much more experience across the country, and our process is one of the longest. If you look at the other laws, some of them do have a 48-hour period during the process, but they overlap with the 15 days, whereas ours is tacked on to the end. So that makes our process among the longest across the country.
So Betsy, I'm going to ask if you could get to some closure, simply because we're going to be pressed for time.
Absolutely.
And we may be able to come back with questions or further testimony going forward.
Yes, yes, I certainly can. I would just add to that comment these words of D. Allen's son, whose video is on our website. And he calls the last 48 hours a nightmare. And that pretty much says it all for her case. I won't go into more details. You can listen to it if you like. So please consider removing that last barrier. And we certainly appreciate all the consideration that you are giving. We think that S.74 would remove needless suffering while keeping Act 39 strong and consistent with best medical practice across the country. So thank you for your consideration.
Well, thank you. And thank you for your work on this. I know it's been a long time, including with your parents, who many of us know and worked with. Thank you. Questions of clarification? Okay. All right. So next on our list is Charity Clark of the Attorney General's Office. And Charity, thank you for being here. I know you have some specific comments to make about the bill, and I think that's going to be helpful to the committee.
Sure. Thanks for inviting us to testify on this bill today. Just a couple of things. We were asked to testify as to the immunity portions of the bill. So I see those as the good faith section in C that was added. I first wanted to comment on the change in telehealth, which we fully support, and it's actually really wonderful to hear the testimony today about that. We would just suggest that safeguards be put in place. Obviously, it's different to be in the room with the patient versus on the screen, and would be happy to work with you on this, or legislative counsel thinking about what those safeguards might look like. I also, with telehealth, wanted to flag an issue that I probably came up in 2013, but maybe with telehealth is going to be more of an issue that you might want to think about, which is the potential implications for where the healthcare provider
Charity, you're frozen if you can hear us. And sometimes it helps to turn off the video. It's probably the windy weather. Okay, so what I'm going to suggest is that we move to Kim Callanan. And Kim, you're not frozen.
I'm good.
Okay. Erin is, maybe you could communicate with Charity and let her know that we know she's frozen and we'll try and get her back in.
Will do.
Okay, thank you. All right, Kim, why don't you go ahead?
Great. Thank you so much for being here today, for allowing me to be here today. My name is Kim Callanan, and I lead Compassion and Choices, and we are the largest national organization that works to improve care and expand options at the end of life, including working with different states to authorize and then implement medical aid and dying laws. And we worked closely with Patient Choices Vermont on the authorization of this law, along with, of course, the legislature, as well as the early implementation efforts. So I'm delighted to be here today, and my specific unique role will be to be able to share with you the experience in the other authorized states where we work across the vast majority of them. And what I thought I would do is start out and share with you. Oh, it looks like I cannot share my screen. So I'll just, in my testimony, I think there are some slides. You can refer to them there, and I will just go ahead and talk through them. So first, just to give you guys some context, and Betsy went into this a little bit in her testimony, but right now, across the United States, 1 in 5 adults have access to the option of medical aid and dying across 10 states and Washington, D.C. Vermont has played a very important role in the authorization of medical aid and dying, being the very first state legislature to authorize the option. In the states that came before you, Oregon and Washington were authorized by ballot, and Montana was authorized through the courts. And it looks like Erin told me I can share my screen now, so I'm gonna go ahead and do that. Can everybody see that okay?
Yes.
Great. So you can see that after Vermont authorized the option, that right after that, a flurry of other states followed suit. So California authorized by the legislature, Colorado was another ballot initiative, but then DC, Hawaii, New Jersey, Maine, and New Mexico all authorized through the legislature. So on behalf of all of those other states, I would like to profoundly thank the lawmakers of Vermont for your leadership. You've really not just brought a compassionate end for the residents of Vermont, but you've helped pave the way in other states as well. It's important to know that while this option brings a profound peace of mind to lots of terminally ill residents, that very small numbers are going to choose to use the option. And this is true in the other authorized states that already have the provisions that we're hoping that the Vermont legislature will pass today. So as Betsy mentioned, it's 116 residents of Vermont have used the option across the years it's been authorized in Vermont, but across all of the authorized jurisdictions, all 11 jurisdictions in many, many years, decades combined, just over 5,000 terminally ill adults have used the option. It's important, though, to know that what the data shows us is even though small numbers of people are using the option, it's bringing peace of mind to lots of other people. And it also, as you've seen in Vermont, it improves end-of-life care across the board by creating better conversations between doctors and patients and encouraging earlier enrollment into hospice care as well. In terms of who uses the law, data is collected across the vast majority of the authorized states, and we see pretty consistently the same trends and patterns. So you have about 3/4 of the people who are using the option are over the age of 65, with the median age being in the mid-70s. It's an equal percentage of male and female, which I always find to be particularly interesting. And people give a large number of reasons why they're choosing to use the law. We really think about it as being the entire experience of what happens to somebody at the end of life. It's everything from the loss of autonomy to fear about suffering to a reduced quality of life. And it's really the totality is why people are choosing to use the option. And as Dr. Barnard said in her testimony, the vast majority of people who use this option well before they were terminally ill were already clear that they wanted to be able to die on their own terms and that this is the option that they wanted. So people don't come to this and make the decision lightly. It's something that sort of is a core part of who they are as a person. Most are receiving palliative care or hospice care at the time of death, and it helps more people be able to die where they want to die, which is in their home. Generally speaking, the family is very involved in the decision. People who do choose the option tend to have advanced education, and the vast majority are insured. So that's just a little bit about what the data across the other authorized states shows about who chooses to use the option. In terms of the specific provisions that you're talking about doing here in the state of Vermont, I think what's most important to understand is that those are already the law across all of these other authorized jurisdictions. So we're not asking for changes here that are outside the practice that's taking place across all these other jurisdictions. And in those other jurisdictions, just like in Vermont, there aren't substantiated incidences of abuse or coercion. What we do know is there are a lot of regulatory roadblocks, that 12-step process that somebody has to get through to be able to access the law when a person is terminally ill. It's quite an extensive process. And the changes that we're making here are not going to make it so that patients have more vulnerable populations it doesn't change the experience for them. So specifically in terms of telehealth, it's important to remember that all of the laws that govern the practice of medicine also govern medical aid in dying. So by removing the language within your provision related to telehealth, what you're simply saying is the laws in place that govern telehealth in general will also be in place to govern medical aid in dying. And so what does this mean? It means that video-only appointments will have to be used in order to establish a relationship for the person, which gives that experience that Dr. Barnard was talking about. It means that a person can't get through that whole process without those video appointments. And it means that you're treating the practice of medical aid in dying in the same way we're treating other medical practices. This is what is done across all the other authorized jurisdictions. And again, what the experience has been, especially in the time of COVID, is it has actually helped to protect vulnerable populations because you haven't forced them to risk getting COVID and leaving their homes, which actually is a pretty horrific death, in order to access the option that they want. So I would say it brings a lot greater compassion, especially for a person in a state like Vermont that has lots of rural areas. It takes away the burden of having to travel several hours in order to be able to get the care and the experience that they want. The second provision around the 48-hour time frame, the trend across the country is actually to move.
Kim, I don't want to interrupt but we're running into some time issues this morning, and your written testimony that you have provided us is very clear. Okay. So if you could just give a couple of sentences about the last provisions and then wrap up, that would be terrific.
Great. I will do 30 seconds. On the immunities, again, they're across all of the other authorized states, and in the 48 time period, this is just consistent with the other states. So, happy to answer any questions if people have them, and I appreciate the opportunity to be here. Thank you.
And thank you that the information that you provide is extremely helpful, and we greatly appreciate it. We have a question of clarification from Senator Hardy.
Thank you, Madam Chair. Kim, you brought up an issue that I hadn't, unfortunately, I hadn't thought about before, and that in your statistics about who accesses medical aid in dying, specifically people who tend to be more educated and insured. And I'm wondering if there are provisions in other states that could improve, that we might consider that would improve sort of health equity and access to this medical care?
Yeah, that's a great question. So I think from an access perspective, first of all, I do think it's important. We want to get these changes through. So we wouldn't want to do anything to the bill this time around that would slow things down in any way. But some of the other states, their state Medicaid program covers the law, and that does help to bring about greater access to the law.
Okay. Thank you. That's helpful. I'm wondering, does our Medicaid program not cover it? Does anyone
I
know?
will defer to Betsy on that.
Right. Our Act 39 patients in general have to pay for the medication themselves. Generally, it's
Well, and here's what I'm going to suggest, Betsy. Thank you. I
Yeah.
think what we'll do is we'll get clarity from our legislative counsel.
okay.
Yeah, I think that would help. And Ruth, it's a great, Senator Hardy, it's a great question. So we'll try to get some clarity on that.
Great. Thank you.
Yeah.
Thank you, Kim.
Sure.
All right. Yes, thank you for your testimony. So Charity Clark is with us by telephones. Charity, why don't you go right ahead with your testimony? And I know
Okay,
that, yeah, go ahead.
I'm gonna keep my camera off. One, because I'm on my camera and you always look gigantic when you turn your camera on, but also I'm nervous about the connection, maybe because of the wind. So I was just flagging, I hope that you heard me start this, but to think about what the implications might be for where the healthcare provider is physically located. In other words, are they out of state, in a state that does not have a law that would provide the immunity? So wanted to flag that as an issue. And then the second kind of main topic is this addition to a paragraph that references good faith. So currently, as others have discussed, there is this regimented process for facilitating patient choice at end of life, and any good faith is implied in that. So the new section makes good faith explicit. And from a criminal perspective, the current process is very strict, it's regimented. So long as these steps are taken, the report is made to the Department of Health, the physician isn't subject to criminal liability. The proposed subsection introduces explicitly this new element of good faith. So I'm wondering if this might raise questions about the process, because it does introduce this new element. And, for prosecutors or the Office of Chief Medical Examiner, Department of Health, I'm not sure if there was, it sounds like the reason for this section relates to making sure that pharmacists are explicitly included in the immunity. And it might be simplest just to add pharmacists or others to the list with physicians than to add this new section, which I think does raise some questions about the paradigm right now as the law exists. I'm happy to speak with legislative counsel about particulars on this, but those are the couple of things I wanted to flag for the committee. And I'm sorry again for my connection issues, but glad I was able to finish the testimony today. Thank you.
Thank you. And again, this sounds like something that our leg counsel may be interested in helping us understand. So we will, it would be helpful to have you connect with leg counsel and we'll work through that and try and make that happen.
Great. Happy to. Thank you.
All right. Thank you. Terrific. Who is next on our list? I think it's Sarah Teachout of Blue Cross and Blue Shield. And Sarah, thank you for being here.
Great, thank you. Sarah Teachout, the government and media relations person for Blue Cross and Blue Shield of Vermont. I will be quite brief. Blue Cross supports the passage of S74. And in particular, we believe that the provision about immunity that applies more broadly is very important for this bill. What we've noticed in trying to support our members who are looking to fill the prescription is that there's only one pharmacy in the state of Vermont that can do so right now, or is willing to do so. And we believe that this is one of the reasons that pharmacists have not been participating. And so if you broaden this immunity piece, there might be more options for patients for filling the script. And that's something that we work on with our members when they've requested it. So again, we really do try to support our members with all of their healthcare choices. And we believe that this will make the law work better for patients in Vermont. Thank you.
Thank you. Okay. So we'll move along unless there's a question of clarification. All right. And David Englander is here from the Department of Health. Welcome.
Madam Chair, it's wonderful to see you. Good morning, members.
Good to see you.
My name is David Engler. I'm the Senior Policy and Legal Advisor to the Department of Health. The department support, I think we're a little short on time, so I will uncharacteristically try to be brief. The Department of Health supports these proposals for the reasons articulated earlier. Actually, this is the Act 39 in 2013 was the first piece of legislation that I worked on in my role at the Department of Health. So the department has a long history, so folks know. The role of the Department of Health is to collect the information provided by doctors and patients. That information is held confidentially, and then we produce a biannual report that I've provided in my testimony. We also provide support to doctors and patients to the extent that they have questions regarding the law, although largely this is decisions made between doctors and patients. With that, I'm happy to take the committee's questions.
I do have a question, and you've given us the full report, which is terrific. It's 4 pages long, so we won't have any difficulty getting through it. And then you've also given some other information. But I guess my question for you, is there anything in the report or the reporting that you have seen that was a surprise to the department in terms of how the process is going or the data collection?
A surprise? No. It has been, I would say, it's been surprisingly smooth from the department's perspective, understanding that doctors and patients are leading the complex lives involved with end-of-life decisions. There certainly has been, there's a lot of work on the department side trying to gather this information. Sometimes there's a misunderstanding about how the law works, so we do a lot of outreach to providers. The law, as folks familiar with the law know, it lays out a stepwise process that doctors and patients have to go through. The Department of Health did produce forms so that all providers can use those rather than trying to generate them themselves. So on the whole, it has been fairly smooth. The calls with questions regarding the law tends to ebb and flow with reporting, cases, patients bravely coming out and talking about their experience, and then when we get more calls, and then that tails off.
Okay, thank you. And you have your frequently asked questions there, which is very helpful. Senator Hardy, I think Senator Hooker, you had your hand up first, and then Senator Hardy.
Actually, Senator Hardy did. So
okay, thank you.
Thanks, Cheryl. This is not necessarily a question for David, but Charity, who is not on the screen anymore, raised this question, and maybe Dr. Barnard knows the answer, about telehealth and medical licensure. My assumption is that just like with any physician, they would have to be licensed in the state of Vermont to provide telehealth for this service. So it seems to me that it would be covered already under medical licensure law in another part of the statute. Maybe this is a question for our legal counsel as well, but is that your understanding, Dr. Barnard?
Well, I guess, listen, I'll let Dr. Barnard answer, but I think the Department of Health can answer that based on the Board of Professional Regulation, but go ahead, Dr. Barnard.
Yes, I agree with what you said, Ruth, about the issues being guided and defer to others with more expertise in the legal realm.
Okay.
And I agree. Yeah. I agree with Senator Hardy that is the case.
Okay, so there's not like we don't need another separate provision for this new telehealth. It's already covered under the fact that physicians have to be licensed to practice in Vermont.
Well, Charity and I haven't spoken in detail with regard to the AGO's concerns, so I wouldn't want to opine that broadly, but certainly on its face, that would appear to be the case.
Okay, I just want to make sure we get clarity on that before we move the bill forward, but it seems like it probably is already covered, but thank you.
Right, so this is another, I'll give that task to David Englander. I'm going to add that to our list of clarification with our ledge council.
Also on my list is to determine whether or not Medicaid covers these services. I've already reached out to my colleagues and we'll get the answer by the end of the day.
Thank you so much. Senator Hooker.
Thank you. And actually, Senator Hardy asked a question that's very similar to the one I had. And I was just wondering if in the reporting you differentiate between doctors who are located in the state and those who are located in other states.
We don't. In order to participate, they have to be Vermont licensed physicians.
Okay, and we will, of course, work with Ledge Council as we go through the bill again and look at some of the responses that we're getting. And as soon as we get Medicaid, that'll be helpful, and then we'll learn further what language might be necessary on the pharmacists, how much language and we'll have Charity Clark working with Ledge Council initially, and then we'll bring it back into committee, talk in committee.
Madam Chair, I do have one point, if I may, which is that the issue of concerns about liability coverage for pharmacists arose immediately after passage of the bill. The department actually reached out to the Office of the Attorney General, and you can see on the penultimate question of the FAQ, we have the statement of the Attorney General that if a pharmacist acts within the scope of her practice, that actions of the law are covered by liability. So what S74 does is it makes explicit what has been implicit and understood. I just want to be clear that it codifies the status quo in a way we would now have positive law, but it doesn't represent a shift, legally speaking.
Thank you. Thank you for that clarity. It's helpful. Okay. Committee, any other questions for our witnesses today? And just as I indicated earlier, we do have one witness who is unable to be here because of a family emergency. And so we will add that testimony as quickly as we can. And we'll try to get responses back on this legislation and go through it for some final discussion and markup as quickly as we can as well. Oh, okay. Thank you all for being here. We're in the mode of switching gears and turning a corner. And we're going to be looking next at parent-child centers and a bill called S91. So I'm not sure you need to stay around, but thank you all for your testimony. It's been excellent.
Senator Lyons, did you want to take a break first, or?
I think that is Miranda Gray here.
Yes, everyone's here.
I think we should just keep going ahead because I know she is on a time crunch.
All right, I will admit that.
And we will try to take a break, but I can't promise. If folks need to take a break, go ahead. Okay. We've just been through a very demanding set of testimonies. And so now we're just taking a deep breath. And we're switching to S91, parent-child centers. The issue that we've worked on significantly in the past, and we're very pleased that you all are here to talk with us about this bill. Miranda, Commissioner, Deputy Commissioner, is it Deputy Commissioner? You have a time crunch, and I think it would be helpful for you to be here during as much of the testimony as you can. But you are, I think, first on our agenda. And if you could please speak to S91, I think I sent you some context for that, so thank you.
Miranda's having some tech issues, so she's going to come back.
Okay. We had her camera.
It wasn't allowing her to turn her camera on, though, for you to see her.
Oh, okay.
Should be right back, though.
Tech's a good way to avoid responsibility, I think. Could be, huh? No. Miranda, are you there? Can you unmute? Oh,
Good morning. Yes.
Finally.
My apologies. I don't know what was happening. The buttons were not working for me, even a little bit.
Well, we're pleased that you're here at last, and thank you. We're taking testimony, as you know, on S91, and I think we sent some context for that for your testimony. So it'd be very helpful for you to go right ahead, introduce yourself for the record, and we would be happy to hear what you have to say.
All right. Thank you. Good morning, everyone. For the record, my name is Miranda Gray. I'm the Interim Deputy Commissioner for the Child Development Division. I thought I would begin this morning by talking about the work that the Child Development Division has been doing with the parent-child centers, and it has been doing this work for several decades. The parent-child centers are responsible for serving expectant and parenting families of young children in their designated geographic catchment areas under integrated grants with the Child Development Division. A specific focus is to be paid to families who are experiencing medical, socioeconomic, or developmental challenges, including substance misuse, housing instability, or homelessness, and/or involvement with childcare. The purpose of our grant funding to date has been to promote the development of parenting skills, especially in young parents and primary caregivers, and with caregivers of very young youth. To increase family stability by building strengthening family protective factors in families and providing concrete supports in times of need. Provide referrals to health and developmental services, and engaging community-based efforts to develop and operate, expand, enhance, and coordinate initiatives to strengthen and support families, including efforts aimed to reduce the likelihood of child abuse and neglect. These grants fund the following prevention activities within the PCC's 8 core services. So parent and caregiver education and support groups, play groups, resource supports such as administering community-based child abuse prevention funds, community development, so actively participating in groups that support families, including but not limited to the regional Building Bright Futures councils, the regional Children's Integrated Services team, and regions initiatives that include and/or engage families. And then lastly, the information and referral. So the parent-child centers will serve as a clearinghouse for general information about child development and parenting, information about local and statewide resources for families, and early detection of health, mental health, or developmental needs or delays. And this includes things such as Help Me Grow, services to welcome babies into the community, as appropriate to determine insurance status of all clients served, and assist clients in accessing Medicaid coverage, sharing information about health care, housing insecurity, homelessness resources, and substance abuse wraparound supports. These activities are delivered in a variety of settings, including the parent-child centers, families' homes, and other community locations, and online as appropriate during the COVID-19 pandemic. And then just of note, the length of time spent on each type of service depends on the type and service needs of the families. I thought it would also be nice to highlight some of the child development and parent-child centers work together through the COVID-19 pandemic. The parent-child centers assisted the child development division with distributing baby wipes that the state had obtained through FEMA. And they were also critical partners in supporting families' additional needs, including but not limited to access to more food. So the lack of access to meals at places like schools and childcare when it was stay home and stay safe, paying higher utility bills for the same reasons of people being at their homes more, and obtaining diapers and wipes and other goods that were harder to find in stores, or families were not able to get to stores because of extra precautions that had been put into place, such as traveling with people outside of your household. These are just a couple of examples of how our work together, has gone through the pandemic. And now specifically to your questions this morning about our review of S91, I really just have three main points, and it's more so questions.
Okay.
So the amount of funding and the request for the annual inflation is currently above what is budgeted by the department and the agency. So I just wanted to highlight that for the committee. The Child Development Division would want to know more about the accountability measures and how those are developed. We would want to ensure quantifiable accountability measures that exist ahead of allocating the funding. And then the last is the legacy designation for the current parent-child centers. Just currently, there are some discrepancies amongst parent-child centers in being able to provide all of those 8 core components. So just wondering about what happens during the gapped time of parent-child centers, moving to be able to provide all of the services. That was really my somewhat brief, but what I have to share with you today, and just would like to thank the committee for providing me this opportunity to give our thoughts and questions more so on this bill. And I welcome any questions that the committee might have for me.
Thank you. And now wait, I'm trying to remember if this is the first time you've testified in our committee.
I was here last week with Commissioner Brown.
Of course you were. Okay.
That's not a problem.
You know what? The time seems like ancient history right now because of so much going on, but we appreciate your being here. I guess I will ask you a question, and given well, your comment on accountability measures is key. Do you think that the department and the agency generally would support ongoing work to develop those accountability measures and to work with the parent-child centers on that?
Yeah, I think that we would welcome that opportunity to work together.
Okay, and then the other question is on the gap piece, and how do you see the department sort of facilitating the closure of the gaps?
Yeah, that's a great question. And I guess one as well that I'm curious for the Parent-Child Center Network, if they had thoughts. I am still fairly new in this role, although I can, just for historical context, I began my career in a Parent-Child Center, the Orange County Parent-Child Center. But a fair amount has changed since I was working with them. So just curious in knowing that a lot of times it is really community-based needs or just the lack of access to different resources. So just wondering, I'm sure that they have thoughts and would welcome being able to be a partner in having those discussions about, how we could close those gaps.
Okay, thank you. That's very helpful. Questions Committee? Yes, Senator Hardy.
Thank you, Madam Chair. Commissioner, Deputy Commissioner, I knew it was a D sound, Deputy Commissioner Gray. You mentioned accountability, and I'm just skimming through the bill, and there are several areas where accountability is mentioned, and your team working with the local parent-child centers to develop accountability measures. Do you have specific language suggestions that you think might strengthen that, or do you feel like what's in the bill is sufficient at this point?
I don't have a specific recommendation today, but if it was an opportunity to be able to follow up I would welcome that opportunity.
Yeah, I think it would be helpful if you feel like there are areas that could strengthen that language to make sure that it meets your goals from the perspective of the department, that would be helpful. The other question I have is in a different area, and this is something that has made me curious. I'm skimming through the bill as there's a provision that a new parent-child center could not be designated any more frequently than every 6 years. And my understanding in talking to the parent-child center folks, and I believe that Donna Bailey will address this a little bit in her testimony, but is that, they just want to be sure that there's not so many parent-child centers coming online that there's a lack of resources or a lack of process, et cetera. And I totally understand that. On the flip side, there are areas of the state that are probably less well served right now, and want to make sure that there's the ability of those areas of the state to bring a parent-child center online if all of the stars align to be able to do it. So I guess my question is do you see some kind of language change that might be helpful to meet those two goals of 6 years seems like an awful lot of time if there's a center ready to go and meets the criteria?
Yeah, thank you. That was an area that I had flagged as well as just looking for the reasoning behind the 6 years. So I look forward to hearing Donna Bailey give me some more insight into that. And so I don't come to you today with language, but I think that is something else that I would welcome the opportunity to be able to suggest how we find, what that balance would look like. As you'd mentioned, like if there are areas of the state that really could benefit right now, but also understanding that does,
So yeah, thank you. And the next step, obviously, for us is to walk. Once we've heard the testimony, then we can start walking through the bill with an eye to marking it up, and having your insight in that would be extremely helpful. Any other questions, Senator Hardy?
No, those are my two for Deputy
The
Commissioner.
twofer. Okay, that's good. All right. So I understand that you are here. You might have to leave, but you'll be around and back. That's good. Because as we hear testimony, we may have other questions for you. I mean, I think Senator Hardy has presaged one of those, but there might be others that come up. So
yes, no, I can stay with you until just a little after 10:30, and then I'm doing another committee.
Okay. Thank you. All right, good.
Thank you.
All right. So Donna Bailey is here representing the parent-child centers. And so Donna, thank you for being here. And why don't you introduce yourself for the record and your title? What is your title for all of the parent-child centers? I know you're in Addison County.
Yes. So, hi, my name is Donna Bailey, and I am the co-chair of the Vermont Parent-Child Center Network. And I am the director of the Addison County Parent-Child Center. And I'm here today with Margot Holmes, who is my fellow co-chair of the Parent-Child Center Network. She's also the director of the Springfield Area Parent-Child Center. So.
Margaret, do you want to introduce yourself now, and then we can listen to the testimony that you each have?
Sure. Thank you all so much for having us. My name is Margot Holmes. I am the executive director of the Springfield Area Parent-Child Center and co-chair of the Vermont Parent-Child Center Network with Donna Bailey.
Terrific. Thank you. And thanks both for being here. So Donna, go right ahead.
Okay. So I can skip the first line, which is my introductions. I am here to ask for your committee support on S91 and to ask you to support our request for funding in the fiscal year 2023 budget. We're asking for a second year of $3.7 million one-time funding for the parent-child centers to support families with young children as they are dealing with the consequences of the COVID-19 pandemic. And we are also requesting an increase in the base funding for parent-child centers by $1.5 million for a total of $4.8 million in the parent-child center line. As you know, parent-child centers have been on the front lines through the COVID pandemic, and we continue to see our families with young children struggling to get through this very, very challenging time. We have been here for them for at least the past 30 years, and we will continue to be here for them, whatever comes our way. We do need support from the state to be able to continue to provide the services and support that our families need, and we are asking for your support in our request this year. The parent-child centers are well equipped to work as community partners with the state and to work with children, youth, and families in our communities. I used to cringe when I heard the statement, if you've seen one parent-child center, you've seen one parent-child center, you know, implying that we're all very different and maybe we should have to look at apples to apples and we're apples and oranges. But I now defend that statement, and I'm proud to say that we are community agencies that have grown to meet the needs of young families in our community and therefore have some differences. We have had to string together diverse funding, and we're able to meet those funding requirements while being responsive to unique community needs. We all provide the 8 core services listed in the legislation. One of the 8 core services, concrete supports in time of need, which is defined as a protective factor that can buffer and support children and families during good times and bad. Concrete supports means having access to goods and services that address a family's needs, such as support for food, housing, clothing, healthcare, and childcare. Some PCCs have diaper banks that give out thousands of free diapers, wipes, and formulas, and some PCCs have on-site food banks, and all the PCCs are statewide recipients of community-based child abuse prevention dollars, which provide flexible fundings for families and immediate needs such as transportation, housing, or childcare that are not otherwise met by other state resources. The Parent-Child Center Network is an well-established entity that provides support and accountability statewide to the 15 existing parent-child centers. We meet as a network monthly and more. We participate in peer reviews, and we work on our own programming and help each other and other organizations to do so. Along with strengthened partnerships with the state, this bill would support the clear designation of parent-child centers, ensuring that all entities within the network are providing the high quality work expected in the legislation and provide the network a role in this accountability. Designation every 6 years provides a PCC that may be struggling to be given time to correct any issues and ensure that they are providing the quality services needed for this designation. If for any reason this was no longer the case, the network would partner in the responsibility to identify a new parent-child center for the specific region of the state. The bill has language for that process if it becomes necessary. Parent-child centers provide a level of care that cuts across prevention, intervention, and treatment. We're part of a continuum of care in the state that has created a safety net for all Vermonters in need. We work with families of all backgrounds, focusing our most intensive programming, Learning Together, for example, on the families most in need. All new parents need support, and we are happy to help with welcome baby programming, CIS services, playgroups, etc. We are helping those Vermonters involved with state systems such as DCF Family Services and Economic Services navigate sometimes difficult state systems. We are helping young families dream of a better life through education and mental health and substance recovery. We help families get and keep housing. Many of us provide childcare in our communities, and all of us help children to get into high quality childcare programs. Again, we are part of the safety net Vermont has so wisely provided for those of us in need at different times in our lives. Parent-child centers make lives better for many families. We create community and connection where there may be little or none. We love these families and are professional and are helping to get families off to a good start so that they can be healthy and strong. Our staff are professionals and work hard for low wages. We know that the most important thing for a young child is a consistent caregiver. We want parents to be that for their children. And when they are working, we want consistency of care for their children. We want our staff to not turn over, so there are familiar faces for children and parents. To do so, we need consistent funding. I have been at the Addison County Parent-Child Center since 1998, and I can tell you, in the time I've been here, and before that, because I worked at Lund prior to being in Addison, I have seen families' lives in Vermont improve and the work of agencies increase professionalism. There is a lower dropout rate from high schools in Vermont, a lower teen pregnancy rate in the state, a higher literacy rate amongst parents, more home ownership in families, a better rate of prenatal care and primary doctor visits. We are doing better, and it's not by accident. We need the support to continue these trends. We have seen the disparities during this pandemic, and we have not reached the mountaintop. Parent-child centers are a good investment. We are providing care in the present for the future. Helping families to become self-sufficient while not isolated from resources and support is what we do. Helping young children be healthy and secure. This is our daily work, and it will save us all many dollars and heartache in the future. Thank you for the work you have done and for the support of this bill and for its funding this year and over the years that have gotten us here. We could not do this important work without your strength here.
Thank you. That was clear, concise, and complete. And we have some other information that you shared with us about all the parent-child centers. It's extremely helpful. I'm going to ask a question in a minute, but I wanted to ask Margot if you wanted to add any comments at this time.
I think the only piece that I would add in, Donna mentioned some of the things that we all have in common. And one of the other areas that we've been working hard on is to align ourselves with the national standards for family strengthening and support. These are nationally accepted standards for organizations like ours, and each parent-child center is in a phase of implementing these standards and assuring that we are aligned with these standards to showcase the high quality work that we are providing throughout the state.
And as you're doing that and implementing the national standards, are you seeing any need for modifying any of that to be Vermont specific?
No, the standards are well set up as a framework for providing high quality care. So it doesn't specifically designate you have to do X number of these kinds of programs or those kinds of programs. It's saying if you are providing family strengthening and support services, here are the things to look at to ensure that you have a framework that does that work in a high quality way. So there aren't necessarily state specific areas that need changing. They've been very purposefully designed to be able to roll out throughout the country in a way that really aligns in a consistent manner.
Okay, thank you. That's helpful. I do have specific questions for you, and then I'm going to go back to the questions that I asked of Deputy Commissioner Gray, now that we've gotten Deputy Commissioner right. And just to see what your thoughts are on working together on some of the areas that she mentioned earlier. But last year we did invest a good deal of federal dollars into parent-child centers. I think it was at $3.7 million, equivalent to what you're asking for again. And do we have any cost accounting of that? And I don't know whether you or whether some of the administration has been keeping track overall, but you as co-directors may have some insight into how that money was utilized.
One piece I will share is that at the sort of last minute before the budget passed, that funding did get switched over to general fund dollars. So it was initially meant to be ARPA dollars, and it did get switched over to general fund dollars, for clarification. We actually are right now in the process of submitting our first report for those grants. And so we will hopefully have additional information, and the state will have additional information in the next couple of weeks as we submit those reports. But my understanding is that the parent-child centers across the state really used those funds to increase their outreach to families who were in additional need because of this pandemic, and to ensure that we had the highest quality programming possible during the pandemic. So as an example, I can share in my center, we had no functioning IT system. And when we all of a sudden all had to go to Zoom and all of those online services, we really had to put some investment into our online infrastructure within our organization in order to ensure that we could provide telehealth services and other services through Zoom and things like that.
Also, Senator, the committee has a report, a part of what we sent in today, and I know there's a lot. So, but the PCC Innovations handout highlights
I saw
how
that.
our money was spent as well.
Yes, it was. I was just looking for specific line items that would help us make the, decide what going forward. The discussion that we had last year was around capital expenditures. So the things that Margot was talking about that become more permanent. And then as we go forward, our committee gets engaged in the appropriations process. And so we're going to want to understand what your request is and how that fits with where you are with the last request and what it means going forward. So at some point, as you're preparing information for the appropriations committee, we will probably ask to see that as well, because then it helps us make decisions about which of the human services and healthcare appropriations we support. It's probably earlier than you've been thinking, but given the complexity of this session, it would be extremely helpful to see as much information as we can, as early as we can.
We're
the
happy
base
to follow up.
funding, yeah, good. And then the base funding request, I think we all understand the salary and other concerns that our workforce faces right now. So we will certainly take that into consideration. And and then going to the comments that Deputy Commissioner Gray made, that this funding is not currently in the agency proposal. That's one. So that's probably a negotiation process that's going to happen between several different committees. So this is the beginning of a longer conversation. Then the accountability measures that are in the bill. And one of the comments that the deputy commissioner made was that those accountability measures should be completed before the money is appropriated. So can you speak to that piece a little bit? And then to that, as well as to how you might be working with the administration in moving forward. Should we pass this bill, and as the bill is developed, we need to ensure that the language is clear. That's all. Amy, you wanted to weigh in on this one.
Yes, thank you, Senator Lyons. Amy Schollenberger, for the record. I'm the lobbyist for the Parent Child Center Network. So I just wanted to mention that just so you all know, the agency is well aware of the funding requests of the Parent Child Center Network. We've been talking to them about it for years, so it should not be a surprise to the agency that that request is on the table. In terms of the accountability measures, I just did want to highlight that the Parent Child Center line item in the budget is directly tied to the integrated grant that they get from the Department of Children and Families, and the accountability measures are clearly outlined in that grant. So the agreement would occur in that grant agreement. And my understanding of how that works is that the network goes back and forth with the department to make sure that everybody agrees on what the accountability measure should be before the grant agreements are signed. So I think that's where that process would sit. And the bill just really gives the network some responsibility to make sure they're actively participating in that process.
Thank you. That's very helpful.
I will agree with what Amy just said, and Deputy Commissioner Gray also mentioned sort of having an opportunity to talk through exactly what those accountability measures look like and what that language is. And I think, again, that would be within the grant process. And this would give us an opportunity to be a part of that conversation to ensure that the parent-child centers across the state were meeting those accountability measures and part of the network and supporting the work that the state is trying to accomplish.
And also, I just wanted to add, sorry, that one more piece is that we currently, as a part of our monthly network meetings, have CDD representation there. There's a point person, Sheila Duranlo is currently that person from CDD. So, and she brings along other folks from CDD as appropriate. So we have an ongoing regular conversation and relationship there that we can build on and we obviously want that to continue.
Terrific. Okay, Senator Hardy.
Thank you, Madam Chair. This is a great discussion. Donna, I especially loved your line of "we are doing better and it's not by accident." There's a lot of research and data that shows how parent-child centers and other similar programs have benefited children and families over decades. So thank you for that. To the accountability question, Margot, you mentioned national standards that are now available and you're all working toward or trying, aligning with. And in our conversation last year, when we were talking more broadly about childcare and sort of connections to national standards that are specific to childcare, and I know parent-child centers are part of what you do is childcare, but your broader mission. But wondering if maybe a linking, mentioning that in the bill or would be helpful to sort of underscore accountability, and if that might make CDD feel more comfortable with accountability. So that's one thing. I'll just say all my points and then you can respond. Donna, I appreciated you explicitly defining concrete supports. This is something that I've had a concern about because while I know what you mean by them, I feel like it's a vague term to have in statute. And our attorney is not here, but I'm wondering if maybe putting in, for the purposes of just this section of statute, a definition of concrete supports might be helpful. And when Katie is available, I can ask her that. Maybe it's not necessary, but concrete supports, if you think about it in the sort of construction world, it means something completely different. And I'm just
Senator Hardy, this is a good point. So, I mean, circle that. And as we go through the bill for markup, do that. Yeah. That'd be great. Yeah,
everything else in that list of 8, I think is much more, people know what we mean or what you mean by it, but concrete supports I felt like was vague. So then the 6-year question that I brought up before and asked the Deputy Commissioner, Donna, you spoke to that in your testimony, and I understand that's not only a 6-year for a new parent-child center coming online, but existing parent-child centers to sort of get up to standards if necessary. So that makes sense. I'm wondering, what would you say to my concern about if there's an area of the state that's not covered and there's a new parent-child center ready to go? Is 6 years too long of a window to wait? Or do you feel like that's justifiable?
So I think
Uh-oh.
Oh, you just froze, Donna. Maybe Margot can answer the question.
Margot, do you want to step in?
No.
I can.
Here she
we're
is.
happy to do that. So, and we could.
Donna, you were frozen for a minute.
Oh.
So start right from the beginning.
Can you hear me now?
Yes, we can.
It just said you're unstable. Oh no. So that might be another issue, but So sorry about that. So what I wanted to say was that we are happy to discuss language and refer to language that CDD had, or to include language and to be a part of that discussion. So around definitions, around concrete supports and other parts of that legislation. And in terms of the 6 years, that was a number that came up too because of our work. Our peer reviews are typically every 3 years, and it is a big lift to shift a parent-child-centered designation. I would think it's a serious proposition. I also understand that, there might be elements that would be out of, our control, or if there's granting issues or things like that. I think, again, that's worth a conversation, but we felt like it was a time period that could allow, the time span to be seen that there has been work on something, reflection, and then moving forward. But I can't speak for my whole group here. That was the number we came up with, but I think that if there was some sort of sense of urgency, and I know I've been around when a parent-child center went away before, like how could, we dealt with that in a more timely fashion to make sure that all Vermonters were able to receive services.
And I will go back, Senator Hardy, to your first question about the standards. I don't have it right in front of me, but my recollection is that there is language in the bill about aligning with standards. And we certainly have been having conversations with folks at CDD and people who are in the sort of licensing and STARS area for childcare about the national standards and how and where it may align or doesn't align with the work that they are doing. And we are very open to continuing those conversations if there's a place where they all tie together. And the legislation does have some language about continuing to align ourselves with standards. And certainly if there were standards that were put out specifically for childcare, that would be a process we would be happy to be part of.
Okay, I'm gonna, Senator Cummings has a question, but I want to kind of bring us together here. Deputy Commissioner, do you want to respond to the conversation that's going on right now? Because I think this really is what we're going to need to have as we fine tune the bill. So comments.
Yeah, thank you very much. And I will have to depart after this to make my next committee. I welcome the opportunity to continue the conversations and to embed myself some more into those conversations, as they've mentioned, that I do have some staff members that are meeting more regularly with the PCCs. But I think I know, having worked with them in my previous role in economic services, that together we can usually come up with some good momentum forward.
Okay, we may make some recommendations about how that can move forward to help us before we dive thoroughly into the bill, just so you can help us improve it first. We'll see how that goes.
Right.
Senator Cummings.
Okay, I'm just trying to get context. In the past, PCCs have just kind of arisen out of local groups. Is that correct? I think my daughter attended the first year at Vermont College, which then evolved into the Washington County Parent-Child Center, but there wasn't any state, okay, we're putting parent-child centers here. And over time, there's been a move through your network to more kind of centralization. This bill would now give the authorization, the money to the network to be distributed, or would the state distribute it to individual parent-child centers?
How is the grant written, I guess, is the question.
Yeah, I mean, does it go to the network under this bill, or does it go to individual centers?
Amy or Donna or Margot, can
Somebody?
Amy, I wonder if you can help speak to what it says currently. Right now, each individual parent-child center has a contract or a grant with the state.
All right.
Amy, can you help me remember, does the legislation speak to the grant coming to the network?
I think what I would say is I think the goal is that the grants would be negotiated through the network. And I think, I'm not sure there's specific language in the bill that really says that, but I think the idea is that, you know, as Senator Cummings pointed out, for many years, it's been kind of one-on-one with the department. And the idea is to have the network be the place where the grant is negotiated. Probably each individual parent-child center would have to still sign the agreement. It's possible that a more centralized system of accounting could be implemented. The network has certainly talked about that, and that's something legislators have asked about in the past. And so, you know, they've been doing their own work over the years to see, like, how could we get more efficient? How could we deal with the agency in a more coordinated fashion, and also have more consistency across the state, because that's also something legislators have asked for. And that's really, the bill is really two sides, is really sort of giving the network a clear status of a partner with the state, but also creating some accountability and responsibility for the parent-child centers.
So we are moving, there's a power shift going on. If the money goes to you, power goes there. We have parent-child centers. Now this bill calls for 6 years before another one can be set up. But if we haven't, how do we know we have the correct number now? Regions of the state are regions of the state, but there's tend to be mountains that run through the regions, making transportation difficult. Who decides if a parent-child center can be done in East Oshkosh if there's already one in West and there's a mountain through the middle? I think I'm concerned that if power is centralized, then that you then have the power to exclude, and you may find that a group of parents are not happy, maybe culture, not accounting, but they would like something different or closer to home. And this would kind of lock them out for at least 6 years, and then I assume have to get the network's approval. Is that what's happening here?
Donna was going to respond to that.
And Amy, you might want to jump in as well. But you know, I think, Senator, that when I think about the 6 years, and when we were talking about it and thinking about it too, it's a couple of things. One is, I mean, there's a power shift in the sense that, you know, being at the table in an equal way, and being able to have these conversations, not the sense of, you know, we're in complete control and we're not going to talk to the state. Obviously, we want to be a really active partner.
Yes,
and
we do have the money.
And so, yeah. And I think, again, with the agency, it's important to be a part of that system of care and all of the programming, because we have to be at that table and having conversations. So I think that is really the hope. It's not a power grab kind of thing. But I think that in thinking about the coverage, and, you know, we used to have 16 parent-child centers, and now we have 15. Grand Isle is no longer a separate as part of Franklin County. And those conversations over time, as the original legislation did not have 15, but now we do. I think there's also a thinking of, we don't want to create so many parent-child centers that the funding's not adequate and the programming isn't similar, and that we aren't able to sort of rise up with this funding. So we want to contain spending is one piece, but it's also an issue of, and right now we are covered, and we have gone through this for decades, and I've been here for decades, so I know that's true, to think about really each town. So for instance, in where I am in Addison, the district is the county, right? So, and we do have a mountain as Senator Hardy is well aware. And we have a mountain, and so we have a couple of towns, Granville and Hancock, on the other side of the mountain. And so there are times where we have partnered actually with Orange County that meets there, which is, it's far away for them. So how can we do some play groups and things like that? So it is, and that's a response to family need and school need in those communities. So we also work on transportation and have, worked on that regularly for families to be able to access, being in Millbury.
Cabot is a long way from Sherwood Drive in Montpelier.
Absolutely.
Especially in January. It's a good 45-minute drive.
Right.
That's a long way to ask a parent to go. I could see parents maybe in the Marshfield, Twinfield area saying, we can't access this because it costs us $50 a week in gas to get there to get $20 worth of diapers.
That's why we have home visiting.
Who makes that decision?
So, Senator, I'm going to suggest that we're getting into a discussion area.
Okay.
That it might it'll be helpful for us to go through the bill and
Like
hear
weeds.
what parent-child centers and CDD
Yeah.
perhaps come up with in terms of recommendations going forward. And then we'll hash this out, I think, in committee.
Okay.
Yeah, Senator Hardy.
Yeah, I just wanted to underscore what Donna just said. I'm not sure everybody heard it, but one of the 8 core things they do is home visits. And so
Right.
I know during the pandemic that my parent, Donna, and her crew were driving all over Addison County, delivering diapers and food and support and good cheer to people who couldn't get out. So I completely agree, Senator Cummings, that that's an issue. And I think they try to address that within their programming pretty heavily.
So here's what I'm going to suggest, and thank you for your comment, is that we wrap up the conversation for today. This has been great. Parent-child centers have always been on the top of my list, so we'll see what we can do to keep you floating and moving forward. And then we'll come back to this bill. We'll put it on our agenda for markup and discussion and markup, and which means that you've heard some of the questions and the concerns. So as we go through the bill, we will invite you to be here with us if you're, hopefully you'll be available, and we'll have our ledge counsel available. And if you can reach out to CDD prior to our next meeting on the bill, that would be also very helpful.
Thank you so much, Senator.
Thank you. And thanks for all your work on this. This is in addition to everything else you're doing. Thank you.
Thank you all so much.
Yes, thank you, Margot and Donna and Amy. And I want to reach out to Josh Miller at the Janet Munt Center, and to the Lund Family Center, and Tricia Coates, and also to Vicki Patterson up in Milton. I mean, they're a bunch of really dedicated professionals working in our parent-child centers. Thank all of them. And I'm not deliberately leaving anyone out. Those are the ones that I visit the most. Okay, let's take a break, committee. We'll come back at the dot of 11. Thank you all for being here. Aaron, you can take us off YouTube and we'll take